Our first speaker is Dr. Tapan Kadia. Dr. Tapan Kadia is a professor in the leukemia department at MD Anderson Cancer Center. Dr. Kadia is actively involved in clinical and translational research for the treatment of patients with leukemia. His particular focus is in developmental therapeutics in acute leukemia, including individualized frontline therapy, biologically rational targeted therapy, and longer-term maintenance strategies in AML and ALL. Dr. Kadia is the principal investigator on over 20 active clinical trials, and he has authored over 160 peer-reviewed articles, numerous abstracts, and has been invited to present his research nationally and internationally. And with that, I will go ahead and turn it over to Dr. Kadia to get us started with the first topic for today, which is the treatment of younger and older patients with AML and maintenance therapy.
Okay, thank you so much. I'm just going to share my slides. I'm really delighted to be here, everyone. So please make sure you participate in the roundtable, because I really am looking forward to your questions and answering them. So as I said, my name is Tapan Kadia. I'm currently in the Department of Leukemia. I treat AML mostly. And what I'd like to do today is to take you through sort of the paradigm of how we treat acute myeloid leukemia at MD Anderson. We've got a lot of slides. A lot of these slides are data slides. Some of them are, full of survival curves and response rates and things like that. But I wanted to get a few things sort of across to you in terms of how we approach the treatment of AML from the start all the way to remission and then even post-remission therapy. And in this talk, I want to kind of bring three big points to you. First, we know now, which we didn't know as well many years ago, that AML is very heterogeneous. It's very, very different from one patient to the next, from one episode to the next. So from the time of initial diagnosis all the way to relapse and then post-relapse. So it's really important to recognize heterogeneity of AML at the onset with the use of new techniques like next generation sequencing, molecular sequencing, mutation analysis, cytogenetics, and some of the other new techniques we have. We are now able to dissect different AMLs and understand really the biology behind their disease. And we've been able to therefore identify subgroups of different AML. Some AMLs will respond well to intensive chemotherapy. Some may do better with targeted therapy. Some need a combination of therapy. Some are candidates for a stem cell transplant when they're in remission. Others may be cured with chemotherapy alone. And once we recognize and identify these subgroups, we need to understand to individualize our therapy, to treat each individual patient and subgroup based on its own unique biology. So currently in practice, we have several examples of this, like acute promyelocytic leukemia, where we use therapy that is unlike any other therapy that we use in AML, where we use something called ATRA and arsenic, achieve cure rates of 90%. Core binding factor AML, where we use intensive chemotherapy. FLT3 mutated AML, where we use targeted therapy with chemotherapy. So there's a really wide heterogeneity. And the first thing that we need to understand is that wherever you're being treated, hopefully in a large center that has expertise, they need to really stop, understand the individual heterogeneity, and approach that AML individually and not just give a one-size-fits-all approach to everyone. The second thing is that there is a total therapy approach. AML is not a disease that's going to be sort of a one and done or 6 months and done in most cases. It's a disease that's going to require long-term therapy and a total therapy approach from the start, a plan from the start to the end of what's going to happen with this patient, whether it be selecting the therapy, achieving remission, giving some post-remission therapy. Is the patient going to have a stem cell transplant, and then post-transplant maintenance therapy? So this requires a commitment from the physician, from the patient and their family to understand that this is a life-changing process and it will require a long-term commitment with close monitoring and prolonged maintenance therapy. And finally, recently, and as Dr. Short will go into this in a little more detail, is the importance of detecting something called MRD, or minimal residual disease. This is after patients achieve a complete remission. Everyone's happy, everyone's excited, their counts are recovered, they have less than 5% blasts. But what we know is that there's still disease present at very, very low levels that we may not be able to detect with a microscope, but that we can detect with newer techniques, which are the basis of MRD. And we need to figure out how to monitor this MRD over the long term and what to do about it if we see MRD or if it recurs once it's gone. So What I'm going to do now is I'm going to go through some of the ways that we approach AML in the front line, so newly diagnosed patients. We'll go through intensive chemotherapy, which is what you've heard about traditionally in AML, and that we still reserve for most of our young, fit patients with acute myeloid leukemia, but also some of the older patients who have disease that's very curable with intensive chemotherapy. Then I'll move into some low intensity therapy, some of the new things that we're doing on clinical trials and where we're advancing. We'll do some targeted therapies after that, and then I'll touch briefly on maintenance therapy for patients who are not eligible for bone marrow transplant. So as I mentioned, the first thing that we need to do when a person comes in with newly diagnosed AML is to stabilize them, right? To make sure that if they're sick, give them antibiotics, give them chemotherapy, get their disease under somewhat reasonable, stable control, because it is a life-threatening disease that rapidly progresses at the start. And so once they're stabilized, then we need to characterize the leukemia. This is just a sort of a picture kind of diagramming many of the things we do. We look at morphology, we look at flow cytometry, which is surface markers, we look at chromosomes, we look at their mutations, and based on this, we come up with kind of an idea of which subtype or what subgroup this falls in. So at MD Anderson, we do a very quick molecular screening, which takes about 24 to 48 hours to complete after your bone marrow is done. It checks these 10 mutations, and now we have even more. And these mutations are important because they quickly give you an idea if anything is targetable and whether you'll be eligible for one of these clinical trials. About 3 to 5 days later, we get something that looks like this. This is our 81 gene mutational panel. This gives you a comprehensive screen of all the potential mutations in acute leukemia. All the ones that are circled are the ones that are mutated in that patient's gene. And so once we have that, we can say, aha, okay, this patient has intermediate risk AML. This patient has adverse risk AML. We need to maybe treat with this therapy. And then this is something where I would consult the stem cell transplant doctor early and say, look, let's get this person seen by transplant. So when we are in remission, then we can quickly move to transplant, donor is available, et cetera. And finally, we do something called translocation panel, which looks at different translocations or when chromosomes are stuck together, because that can give us ideas for new therapies and also determine prognosis. We know that the genetic landscape of AML, as I mentioned, is very heterogeneous. This is just one snapshot of all the different changes you can have that includes mutations and chromosomes. And our job is to sort of put this all together and say, okay, if you have this mutation in this chromosome, A, what is the prognosis? Is there a reasonable chance you'll respond to chemotherapy? And B, what is the perfect therapy for that patient? And even C now, and Dr. Short will show you this, is can we monitor this leukemia even when it's in remission by looking for some of these mutations to see if they're still present. And this allows us now to really separate the prognosis. You can see these are survival curves. So the way to read these is if you look at the bottom is the number of years, and you look at the y-axis, it's the percentage. And so, for example, at 4 years, what percentage of patients are alive? And you kind of go up and look. For example, the green curve, which is acute promyelocytic leukemia, at 4 years, about 90% of patients are alive and in remission with their disease. And so the different survival curves give you an idea of how many percentage of patients. And so the lower the survival curve, the worse the outcome with that particular subset of leukemia. But you can see how heterogeneous it is. Some people, have 5-year survival of 80 to 90%, where some people are not even alive at 5 years, for example, among those with complex karyotype or P53 mutation. So it's a really strong marker for prognosis and really allows us to plan therapy and life in general overall. This is one of our classification system, what we call the ELN risk classification system. And this where we use can kind of incorporate the molecular and cytogenetics to come up with these with this favorable, intermediate, or unfavorable prognosis and act accordingly. One of the great things in AML, at least in the last 4 to 5 years, or 6 years rather, has been just an explosion of new therapies in acute myeloid leukemia. Because we recognize the heterogeneity, because we understand the biology a little bit better, we have been able to discover new therapies that work really well in AML in specific subsets, ranging from midostaurin, which is a FLT3 inhibitor, all the way to enasidenib and ivosidenib, which are inhibitors of IDH1 and 2. And these are in those specific subsets, right? They don't work in all AML. Gemtuzumab ozogamicin, which is an antibody I'll show you about in a minute, which is very active in a subset of AML called core binding factor AML, or favorable risk disease. And so we know that we can use that with intensive chemotherapy, even among older patients, to achieve good remissions. Venetoclax has probably been one of the biggest breakthroughs that we've had, which allow us to treat older patients more effectively with low intensity therapy, preserving safety, but still increasing efficacy. Drugs like oral azacitidine and decitabine allow patients to take some medication orally. We have CPX-351, which is a safer form of 7+3 intensive chemotherapy that's active in secondary AML. So a huge number of new discoveries, new drugs available that give us more tools in our toolbox to be able to individualize our care for patients with AML. So the landscape of AML looks something like this, right? We see the patients, are they fit for chemotherapy? Do they have lots of comorbidities? They have diabetes, hypertension, heart disease. Once we figure that out, see if they can receive intensive chemotherapy versus not, we make sure we profile the AML itself. And then we kind of divide them. Are they eligible for intensive chemotherapy or ineligible? We always consider clinical trials as our first option because these are among the best and most innovative approaches, which have been sort of looked at by experts as well as by the IRB. And so we look at people, for example, on the left who have various mutations or chromosome abnormalities and treat them with either intensive chemotherapy on the left. On the right, among those patients who are ineligible for intensive chemotherapy, who need low intensity therapy, we have strategies now where we incorporate venetoclax as well as the different inhibitors with low intensity therapy. So that doesn't give you as many side effects as, for example, as intensive chemotherapy would in patients in their 70s and 80s who may not be able to tolerate the most intensive therapy. All right, so let me just go through briefly some of these chemotherapies, and I'm just going to give you a brief, glance of these because I don't think it's important necessarily in this group to get into the details of response and all this kind of stuff, but to give you broad strokes to show you how we think when we see a patient with AML. So among patients who are intensively treated, where do we really use intensive chemotherapy? So I told you about gemtuzumab ozogamicin. This is an antibody which binds to a surface marker called CD33 and really improves the outcomes on the left as you see those curves in patients who have core binding factor or favorable leukemia. So once we have the genomics and we decide this person has a CBF or a favorable leukemia, we want to incorporate gemtuzumab as part of their chemotherapy regimen and give them intensive chemotherapy. Well, you say, wait a second, I'm 70 years old, I'm 68 years old, I can't tolerate intensive chemotherapy. I get it. And we have this discussion with the patient and their families. We say, look, we think that this AML has the potential to be cured. We don't say the word very often. So if it does have the potential to be cured, can we try to take a chance to try to cure this by using intensive chemotherapy? But oh, by the way, because you're older, because maybe you're unfit, we'll reduce the doses of the chemotherapy. We'll give it over a certain period of time where it can be tolerable, even though it is intensive. So it's not like it's going to be zero intensity, but it can be tolerable. So we try to adjust it based on age and fitness. And among those people who absolutely cannot receive that intensive chemotherapy, we use things like decitabine, which is a low intensity therapy, but we still incorporate that gemtuzumab because of what I showed you and how well it works in that favorable subtype of AML. In younger patients who are otherwise fit and ready for chemotherapy, we use our regimen CLIA plus venetoclax, which was developed here at MD Anderson, which is cladribine, idarubicin, hydroxytyribine combined with that drug venetoclax. The venetoclax is approved in older patients with low intensity therapy, but this is a clinical trial where we're incorporating that with intensive chemotherapy just for 7 days to give you better outcomes. And what we found, if you look at this up here, to read in the middle column, the CLIA plus venetoclax, the rate of complete remission was 95%. This is only 41 patients, but 39 out of 41 patients achieved a complete remission with this chemotherapy. That is extremely high. So typically, for your knowledge, the typical response rates is in the range of 60 to 70%. These days now, with this approach, we're achieving high response rates close to 90%. And if you look at the number down here in red, MRD negative, that means that we could not detect minimal residual disease. 94% of those patients who achieved remission were MRD negative, which is a very high rate of response and undetectable disease. So clearly, higher response rate, deeper responses with the addition of venetoclax. And when we went back and compared to our old therapy, which is intensive chemotherapy or IC, and we say Ven plus IC, you can see in each column, the red bar graph has shown higher rates of MRD negative response, regardless of what subtype of AML you were in. So now, in young patients who have good risk or intermediate risk disease, and even some with adverse risk, we use Ven plus chemotherapy in that patient population with the hope to achieve a high rate of MRD negative response. There are still some subsets, for example, P53 mutated, where we may not use this therapy because it may not be beneficial, but this is, again, one of the advances that we've made to improve response rates and MRD negative rates. And you can see the survivals here are outstanding with a 1-year survival of 80% and a 2-year survival of 60, 70% which is outstanding in this group of patients. And even if you take out the consideration of stem cell transplant, 18-month survival, 80% in this population among patients who achieve a complete remission. We also combine intensive chemotherapy with targeted therapy. So this is an example of gilteritinib, which is a targeted FLT3 inhibitor. You can see outstanding long-term survival rates when we combine that with intensive chemotherapy. So what about lower intensity therapy, right? So this is, again, the majority of our patients tend to be older than 65 because the average age of diagnosis of AML is 68 years of age. So you can imagine that a large percentage of our population are older and maybe not fit for intensive chemotherapy. So we've divided programs for low intensity therapy for these patients. So why do we do that? So there are a couple of considerations. As you get older, you have decreased organ reserve, you have multiple comorbidities, your performance status, so your ability to do things actively and robustly may not be as well as it was when you were 20 or 30 or 40 years old. Also, the disease in older patients is different. The disease in older patients with AML, even though it's AML, it's much different than what we typically see in younger patients. They have more secondary AML, they have adverse karyotype. And so this all needs to be taken into consideration. We've developed many prognostic models. We look at your organ function, your age, what your chromosomes are. And to that, we come up with low intensity regimens and biologically targeted approaches, which I'm going to show you now. So for years, the treatment for older patients with AML has been sort of inadequate. So the top two regimens here, the 5-azacitidine and decitabine, yielded response rates in the range of 18 to 20%. That was complete remission rates, right? That's really kind of not great. Median survival, 8 to 10 months. Now, with the use of venetoclax or the incorporation of venetoclax with these low intensity therapies, you can see the third row here, the complete remission rate doubled up to 37%, with now a median survival of 14.8 months. This is in patients with an average age of 73 years of age. So older patients with AML with high response rates and better overall survival. And this is the same data shown there. So we said, can we do better with this, right? So for years, we've been using this backbone of cladribine and low-dose-cytarabine. So we said, what if we take that old backbone that's low intensity therapy with cladribine and low-dose-cytarabine and add venetoclax to that regimen? And so we did that in our trial, and this is how it's given. And what we saw, this is in an older population with an average age of 69 years of age. We saw now a composite complete remission rate of 93%, with 80% of patients going to CR and 84% of those patients who are MRD negative. So again, a big jump in response rates, and this is a clinical trial that's ongoing at MD Anderson for older adults who are age 60 and over with newly diagnosed AML who are not fit for intensive chemotherapy approaches, where you are a little hesitant to give that therapy because you're worried about toxicities. And you can see the outstanding survival here, again, in an older population, 1-year survival, 73%, 2-year survival, 64%, which is outstanding compared to usually rates in the 20 to 30% range for this older population. So we're continuing to build on this using new inhibitors such as gilteritinib and axitinib, and I'll show you some of these examples. But you can see here now a summary of our intensive chemotherapy, which is the first 4 rows, in our low intensity therapy, which is the last row. We're getting high response rates as good as we were with our intensive chemotherapy historically. Going into different subsets, I mentioned there are things called IDH inhibitors. So if you have an IDH mutated AML, we know that the combination of ivosidenib, which is an IDH1 inhibitor with azacitidine, significantly improves survival. Dr. DiNardo in our group has now devised a trial where she combines 5-azacitidine with ivosidenib and venetoclax. So now we're improving that. So the remission rates in that subset with very low intensity therapy, again, outpatient regimen after the first cycle, 92% rate of complete remission. And if you look at here at the dotted blue curve, 1-year survival, 76%. These are numbers that are unheard of for older patients with newly diagnosed AML. Why? Because we chopped the leukemia up into different subsets, we found the subset, and we treated that AML with the targeted agent that worked for that specific subset, yielding the responses that we do. And we need to keep working to know more about the biology, do more research to understand the different subsets, and find therapies for these different diseases. FLT3 mutated AML, another subset here, usually previously considered very adverse, high risk, high rates of relapse. We have combined FLT3 inhibitors with low intensity therapy. You can see going from the top to bottom, increasing response rates with the low intensity chemotherapy. Dr. Davra in our group has combined venetoclax with FLT3 inhibitors, has shown just significant response rates. And now when you combine it with the low-dose therapy, if I pay your attention up here to the first column, 92% response rate with low intensity therapy in FLT3 mutated AML, and on the right, 18-month survival, 80% in older patients who are unfit for chemotherapy. So now it's not that, hey, you're unfit for chemotherapy, I'm sorry, we don't have anything for you, we have to give you low intensity therapy. We are achieving higher response rates and better survival within these clinical trials. And finally, I'll touch upon just a minute about maintenance therapy. One of the things that we realize in many of our older patients is that they get into remission, they do great, but they're not candidates for stem cell transplant because stem cell transplant can be difficult. Now they have new regimens with the reduced intensity conditioning, so more and more patients are becoming eligible, but there are still subsets of patients who may not be eligible for transplant. We now have a maintenance therapy called CC486 or oral Vidasa, which demonstrated here a survival benefit compared to placebo, which is a standard of care. So if you achieve remission and you're not eligible for transplant, you could take CC486 maintenance for up to 2 years to improve your overall survival. We're building on that by adding low-dose venetoclax to low-dose azacitidine. This is a study that we're conducting with aza venetoclax in maintenance for the same population of patients who are not eligible for transplant. And you can see here the relapse-free survival at 1 year is over 65%, which is outstanding for patients who have not received a stem cell transplant in remission. And we're continuing to build on this with other studies where we actually individualize maintenance based on their mutations, whether they be IDH1 mutated, FLT3 mutated, IDH2 mutated, or unmutated. And we basically kind of match up their maintenance therapy based on what mutations they had. And so I'll end here, the key points being that we need to understand that we have many options now to deliver effective therapy safely to patients who are unfit for chemotherapy. We have new backbones, targeted therapies, and AML therapy is going to be a total therapy, folks. It's going to be characterization from the start, incorporate targeted therapy, modify when you need to, follow up closely, watch minimal residual disease, consider maintenance therapy after consolidation, but even after stem cell transplant. So I will end there, and I think Dr. Short will pick up, and I'll be on the panel to help answer all of your questions that you may have. So thank you very much. Thanks for having me. Bye-bye.